Good evening, everyone. My name is Elizabeth, the Education Coordinator for Marlene's Market and Deli. Tonight's special guest that we have with us is Eugenia Lennon. She is uh, a nurse practitioner and then also a certified diabetes care and education specialist. And she is speaking on a very important topic this evening, which is obesity and type 2 diabetes. How did we get here? And Jeannie has some wonderful answers for us. Let's give her a virtual round of applause.
Thanks, Elizabeth. Um, yeah, when I was thinking about what to do for today, I was thinking Shakespeare for some reason. I don't know why he popped into my head. And so I took the soliloquy and I kind of played with it a little bit. So today's topic or title is To Diet or Not to Diet. That is the question. Um, and you can put your British hat on or whatever if you want to say it in British tones. Um, I have been a nurse practitioner since 1995 here in Washington and a diabetic educator since about 2005. My focus right now is internal medicine and primarily diabetes. So, um, So to diet or not to diet? Well, come to think of it, why are we worried about it anyway? I mean, like we have pills for this and we have a little shot for that, and we're all going to die sometime anyway. So why fret? I mean, we could just do whatever we want and eat whatever we want. Um, and now Big Farm has come up with medications to follow us down that path. And we'll talk about pharmacology in a little while. So, why would you want to diet? I mean, it's almost against our natural being, isn't it? Um, so, I came across a couple of tortoises, and the first one says heart attacks, strokes, but not high blood sugar. So, this comes about the reason he's saying this is that diabetes short term blood sugar within control, I mean, even up to 700, won't kill you, but it's the long-term effects of heightened blood sugar that actually does you in. Um, there are molecular changes that happen in every single cell because of the inflammatory process that goes on with diabetes. And I'm talking today about type 2 diabetes, the one that we grow into. Um, and so that's why it's important to stop the progression of type 2 diabetes wherever you are on the continuum. And the second tortoise says, at our age, we should have died by now. Um, and that's because they live for eons. So then he says, well, then should I worry? No, no, dear. You don't have to worry because you just eat plants. All right. Actually, there we go. So what I'd like to do is take on the soliloquy again. To diet or not to diet, that is the question. Pause for a moment, thou shalt. How did we get to the state of ill health? Not long ago, few suffered such maladies. Their name, by any other name, is obesity or diabetes. And so I thought, where did all of this even start? I mean, I won't tell you exactly how old I am, but when I was growing up, we didn't have the pandemic of diabetes. There were some overweight people, but far and wide, it wasn't an issue. So I started going down some rabbit holes to make this make sense. So I came across some statistics, and these are not old statistics. We're going to come up to those in a second. But since around 2000 to only 2016, and I've got some subsequent ones here in a minute, we went from 9.5% of the adult population in the United States who had either diabetes or undiagnosed diabetes. And in 2016, only 16 years later, it went from 9.5 to 12.0 in 16 years. So this is the pandemic of the future, or currently the pandemic. So the obesity, let's see if I can see this. So the obesity started actually back in about 1976. And we said, well, why did it start there? Well, a number of things were happening historically during that time. The popularity of the fast food restaurants started increasing. And everyone, we're creatures of convenience. We like to have things easy. We don't like to cook over a stove. We want it now. Actually, we want it yesterday. And all of this started back in the mid 70s, late 70s. At the same time, women were going into the workforce. Now, I know a lot of women were already in the workforce, but during this time, the song that comes to mind is the Helen Reddy song, I Am Woman. And it was during this time that women started rising in society, and many of them went back to work. Well, when you have women going back to work, mothers, who's going to take care of the kids? We had what do you call it? The kids that had to stay at home by themselves, they needed convenient foods to eat. So that was another thing historically that was going on. At the same time, there was an epidemic going on of ultra-processed foods. Now, when I say ultra-processed, I mean that foods have gone through a processing sequence that you almost don't recognize them from their original source. So mashed potatoes is an example. You mash them up, you take regular potatoes, you process them. And even further, if you have dry flake mashed potatoes that you add milk and such to, they have been even more processed. So with all of this processing, we know now that it creates some changes within our systems. Next, the sweetened beverages. And we're talking naturally sweetened with sugar. The Cokes and the Pepsis and such also took a surge in popularity in the late 70s. And finally, high fructose corn syrup came on board. When you have sugar, it actually is more expensive to process cane sugar into edible sugar than it's more expensive to process that than it is to take corn and make high fructose corn syrup out of it. And the liver doesn't know what to do with high fructose corn syrup. So the fast foods came on board and we started eating, and we didn't We didn't stop. It became more and more convenient. Um, we don't even go into Starbucks to pick up our coffee. We have to get it through the drive-through, and the drive-throughs are becoming um, easier and easier. And you can use your credit cards now, etc. And so this is a huge thing that had started. And again, the convenience. Women in the workforce. A lot of this um, down here in the lower right corner, that isn't me, um, but I had a cap like that when I graduated and with my RN. If you see a cap anywhere these days, you have a second take. The lock key or kids again then had a problem. Who was going to feed them their snacks? Who was going to make their lunches? Processed meats and deli meats became very popular when it came to prepared lunches and sack lunches and such. Um, at the same time, the processed foods started. It's really hard to go through the grocery store and not be pulled to processed foods because they're very tempting. They're easy. You throw the microwave, and it's done. Even you want a fast food. Well, actually, no. I was going to say the pizzas that you can. I shouldn't say names. There's a place that prepares the pizza, and you just take it home and bake it. But their crust and such might well be a processed ingredient. And so our bodies have taken on a lot of this. It's been estimated that between 55 and 60% of what we eat now is ultra processed. So I'm not saying the can of beans, which have a little bit of salt and water in them, that's processed, but it's not ultra processed. What you have in front of you here is the ultra processed foods. And that is what makes up 50 50+% of our diets these days. So the prevalence, and again, this is just through 2016, but you can see graphically how the percentage of Americans, this is male and female, have increased over the decades. And this is the rate of obesity. And when we talk about obesity, we're talking about those who have weight over 30 BMI. This is a 2022 map. This shows you where in the United States the percentages are of people who are obese. And you'll notice that in the South, in the central states, the percentage is high. There aren't any green states anymore. There used to be, and Washington used to be a green state, but it's no longer a green state. In this legend, we have anywhere from 30 to 35% of our population that is obese. When we're talking about morbidly obese, we're talking about Oklahoma, Louisiana, West Virginia. And in those states, 40%, 40 to 45% of the population are obese. So this is a very serious thing that we need to consider. But wait. Do I behold a medication, says thou? Ah, but for how long? And for what cost? There's the rub. So at the beginning of the talk, I mentioned that we have medications now that you can take to decrease your appetite so that you lose weight. Um, and right now, the science that is focused on what we call GLP-1s, right now we know that in order to maintain that weight loss, and the weight loss can be substantial, we're talking anywhere from 20 to 23, 24% of your weight can be lost, but you have to stay on the medications. Now, if you go off of the medications, what happens is that over time, the weight starts coming back up. And so, as an example, let's say you're 200 pounds and you went on one of these medications and you decided that you would stay on it for a while. And over the next 4 or 5 years, you went down from 200 pounds down to 100 pounds. Now, I know that's not healthy and all, but this is just for an example. So you've lost, well, actually, you'd be down to, that's 50%. You'd be down to 150. If you went off of that medication, over the next few years, the weight would start gradually going up. And you would regain about 75% of the weight that you had lost. I hope that makes sense. You don't go back to the baseline necessarily up to the 200 pounds, but you're not going to stay at 150. You're going to gradually go up to 75% of where you were. Another issue as far as the new medications is the cost. And insurance companies are not liking the cost of these new medications. Some have been estimated to be anywhere from $900 to $1,200 a month. And if insurance does pay for part of it, there's still a copay for patients depending on the type of insurance. The copay could be as high as $250 a month. And with Medicare, that even gets a little stiffer because Medicare only has a couple of meds that it will pay for, and you have to use up, probably, let's see, what was it? Used to be $6,000. It's more than that in order for Medicare to pay for all your medical costs, or out of the donut hole. They don't have the donut hole anymore. But we're talking thousands of dollars, and you have to stay on the medications forever. So that's something you could plan for your retirement. So these medications are called GLP-1s, glucagon-like peptide 1 receptor antagonists. And you've probably heard them by their generic names, Trulicity and Victoza. And they are very effective. And how they work are mostly at mealtime. And they're very effective to influence your appetite, and therefore you lose weight. Let me go to this one here. So how these all work, they work in various parts of the body. And the first part is, well, we'll jump over to the second here, is the intestine. And the major thing that these medications do is it slows the rate at which the stomach empties. And so when you have a full stomach, you're not going to be as hungry. That's why sometimes they say take a big glass of water before you eat. It's to fill up some of that volume. These medications also decrease the motility or at the rate at which food processes through the GI tract. Going back to the liver, it says that it decreases the glyconeogenesis and it decreases the setosis, which is another word for fat in the liver. And you might have heard fatty liver disease. A lot of folks that are obese have fatty livers because the fat goes everywhere, including the liver. So these medications, when it says it decreases the glucose neogenesis, what it means is that when you eat, as a type 2 diabetic, when you eat, your pancreas has to contend with two sources of glucose. So it has to send out enough insulin to compensate for the breakdown of the food, which turns eventually into glucose. And it also has to contend with the glucose that the liver is producing. Now, when you don't have diabetes, the liver doesn't produce extra glucose at a mealtime. This is part of the disease process. And so when you eat, if you have type 2 diabetes and you're not on one of these medications, you're sending twice as much sugar into the system that the pancreas then has to deal with. And these meds drop or put the brake on the glucose coming out of the liver. The brain, it affects the brain. We don't know exactly how, but it decreases the appetite and it decreases the palatability. And what that means is that the foods don't taste quite as good as they used to. They don't taste raunchy, but they don't give you that euphoric feeling that you get when you have an ice cream cone, etc. On the muscles, they also work on the muscles to increase insulin sensitivity. So every cell of the body, when you want glucose to go into the cell so that the cells can function, the cellular wall has to become sensitive. And with diabetes, we develop what we call insulin resistance. And so the GLP-1s also, to a lesser extent than some other medications, help to increase the sensitivity of the walls of the muscle cells and therefore help to take up the glucose into the cells. And if you have the glucose into the cells, then the blood sugar drops, which is a good thing. And lastly, the GLP-1s work on the pancreas. It helps to kick the pancreas to put out more insulin when you eat. So this is different than the sulfonylureas like glipizide and glyburide. Those kick the pancreas to put out insulin 24/7, which is not a safe thing to do, especially when you're not eating, because then your blood sugar goes down to a dangerous level sometimes. But the GLP-1s are glucose driven, so they only signal to the pancreas to put out more insulin when there's food in the gut. Okay. It increases the synthesis of insulin within the pancreas. decreases the glucagon secretion because the pancreas also produces a little bit of glucagon, decreases the formulation of fat within the periphery. And there's information now that says that it helps the beta cells to survive longer. I don't know the exact statistics on those at this point, but that's what the GLP-1s do. To go back up here, so we've talked about the mealtime mechanism and how they work also in the rest of the body. There are some potential side effects. There's probably no medication that works 100% for all the people all the time. Because the GLP-1 slow the rate at which the stomach empties, it can cause it to slow too much. Because if you have diabetes, you have gastrophoresis already occurring, which is a slowed process of the GI tract. And on top of that, you're adding another agent that does the same thing. So that's not good for patients that have like GERD or there's some thought that there's some possible problems with suicide ideation. That has not been proven 100% at all, and the jury's still not out on that. And there's some question as to whether or not you experience some hair loss. Another contraindication where you don't want to take these medications is if you have any family history or personal history of thyroid cancer, or if you have any history of pancreatitis. The other caution that you need to take has to do with various procedures and such, so that if you're on a GLP-1 and you're going to have surgery, they want the stomach emptied. That's why when you go in for certain procedures, they say NPO or nothing by mouth after midnight, because they want the stomach emptied. They don't want you vomiting up and getting foreign objects and such in the lungs, which aren't made for food. So if you're on a GLP-1, the recommendation is that you stop it a week before, so that the stomach it can function closer to normal. So what we've done is we've gone over the history part of what has created this problem. The onset or women entering the workforce again, the ultra processed foods, high fructose corn syrup, fast foods, and convenient foods. And so now I ask you a question, and we're not going to, well, we could talk about it during the question answer time, but maybe there's a chance to challenge all of this, that we can gain more control, that we can get our health better, that we don't have to be reliant on these medications. Like I said, before 1976 or thereabouts, we didn't have this pandemic of obesity. So we need to very seriously look at where we are, where we've come from, and get back to the days before the mid-70s. Because diabetes isn't a given in the society. It is if you take the route of leisure and convenience, and not cooking from scratch, but it doesn't have to be that way. I'm going to, Elizabeth, are you monitoring?
Yes.
Okay, so I would like to look at any questions that have come in. Let me look at the chat.
There hasn't been any questions at this time, but feel free, folks, if you got any.
While we're waiting for questions, I will put a plug in here for what I do. I have created an online course. It's a very comprehensive course about type 2 diabetes. And I also am offering a free 30-minute consultation for anyone who is either pre-diabetic or has diabetes to find out where they're at, um, to help them along the curve, so to speak. And I have to preface this very strongly that I'm not your PCP or PCM. I'm not your primary care provider. I am a coach and an educator, and I love to do it. And we can either do this on a one-on-one basis. I would refer you back to the course, just to get the basic information. It's, like I said, it's an extensive course, and it's about 12 hours long or thereabouts. But it's everything you did or did not want to know about diabetes.
Well,
Any,
that's wonderful.
pardon me?
That's wonderful you've created that resource for people.
Yes, and Elizabeth, if you can put my email address on there, then they could email me with a request for the consultation. What I usually do is I send out a questionnaire, and then upon review of that questionnaire, then sit down either via Zoom or phone or whatever, so that we can talk about where you're at, what your questions are, what struggles you're having, trying to make sense of this maze. Diabetes is a very complex condition, and sometimes just having someone make it make sense to you, and then you can be on your way. Like I said, I'm not taking the place of your PCM by any means.
Perfect. Any questions, folks? Feel free to unmute yourselves as well. This is an interactive platform. If you have any questions. Um, oh yeah, you were talking, Jeannie, about the allulose that.
Oh, thank you, thank you. So I went down to Marlene's the other day just to, I must admit, I haven't been down there for a long time. So I just kind of wandered through the store and came across allulose. Now, allulose is in the sugar section. It is made of fruit only. So it's different than the manufactured fruit or sugar substitutes. It's made of fruit. It's a little bit more expensive. I ordered, before I knew that Marlene's had it, I ordered online, and a 3-pound bag cost, I think it was $24, $25. You can use it volume to volume for baking. I wouldn't be making all your Christmas cookies with this, otherwise they get kind of expensive. but allulose is about 70% as sweet as sugar. And Lisa and I are planning a program probably in May down here in Lakewood. And the one that we had up in Federal Way, I actually brought some allulose, and folks dipped a thing in it and tasted it. And everyone said that it had no side effect or no aftertaste.
Ooh.
Yeah, so there's no aftertaste at all. It's very powdery, very, very powdery. It's not at all granular like regular sugar or cane. I'm sorry, regular cane sugar.
Oh, I'll have to try some. I have a couple of friends that have to be careful with their sugar consumption. So that would be a good alternative. Thank you.
Right. Now, a couple of other things while we're waiting for people to ask questions. Like I said, the medications are good. Medications are appropriate for some people. But we also can get around these things. We don't have to get taken out to the ocean in the riptide. Okay? If we look at the warning signs, we don't have to go out that way. And even if you get caught in a riptide, which some people are because they're pre-diabetic, if you use your head, there are ways of not going way out to sea. If you know how to swim around a riptide, okay? So the same thing with prediabetes, and we're not going to get into all of that today, but these medications don't have to be the answer. And it doesn't have to necessarily just be, quote, willpower. I think if we eat mindfully, have your vegetables first, fill up the stomach with vegetables. Doesn't have to be a glass of water, but it could be vegetables, which create that bulk. Slow down your eating so that when you get to the starchy carbohydrates at the end of your meal, not at the beginning, but at the end of your meal, you don't eat as much.
Yep.
Your meal should take 15 to 20 minutes. The other thing that you could do to slow down or how much you eat is while you're preparing the meal, grab a half a handful of nuts. Doesn't matter what kind of nuts. But having something like that in your stomach cues the pancreas to start putting out more insulin.
Ooh.
Okay. So that alone can slow the riptide. Okay. Because you don't want to use up the pancreas's ability to create insulin. So one thing to do is, well, if you were to go and have a big piece of candy, your blood sugar is going to go up, and the pancreas is playing catch up to try to bring that blood sugar level down. Whereas if you were to have a couple of nuts before that candy, now let the nuts work for a couple of minutes, and then you have your candy, the insulin is already on board, and the blood sugar can't go higher.
Oh.
Does that make sense?
Yeah.
So that alone, have nuts on board, or even an apple, something that creates fiber, something. Now, the reason I say nuts is because they have fat. They cue the pancreas to put out some insulin. But because they break down so slowly, the blood sugar kind of goes up and then elongates outward. So it doesn't spike with nuts, but you do get the insulin on board so that when you do eat those other things, your blood sugar doesn't spike. And the same thing goes with protein.
I love that. Whenever I'm needing a snack in between meals, I will go for that apple, especially like a good Honey Crisp. Yum.
And what you should grab for is something that is the next best thing to taking it off the tree. So when we talk about processed foods, minimally processed are the apples that go onto the conveyor belt and get washed and all of that sort of thing, and they get waxed and all. But anyway, or a can of green beans. When you look in that can, you know that they're green beans. Nothing's been added to them except maybe a little bit of salt, and you can also get green beans with low salt. But you can identify what that is. When you process it further and further and further, then you get mush. And the cheap foods out there, and convenient food is cheap because there isn't a lot of protein in it. There isn't a lot of fiber in it. It's been broken down. There aren't very many nutrients in them. Breakfast cereals are almost ultra processed foods, and we're giving them to our kids.
Mhm.
Oatmeal would be better.
Excellent. Gotta love some oatmeal.
When I was thinking about retiring, I thought, well, I'll have a restaurant, and it would be called Buffin Oats. Buffalo, buffalo meat, okay, because it's very lean,
Yeah.
and oats. So instead of getting a pile of French fries, you'd get a mound of oatmeal, and you can garnish oatmeal however you want, but it would be called Buffin Oats.
That's adorable. Oh, yeah, and my grandmother always said, oatmeal sticks to the ribs. It fills you up for so much longer than you would really think it would.
Right. And somebody once said, well, how can you put more protein in it, like for breakfast? So I got plain the other day, and I thought, okay, I don't want to use sugar. What else would be kind of sweet or whatever and have some flavor to it? So I got my whey protein out, and I put some whey protein in the oatmeal.
There you go.
Yep. And some unsweetened applesauce. Oh,
Sounds like the breakfast of champions.
but those are the things that you can do. I mean, whey protein, you could you can use the blender and make a smoothie out of it, but lots of things. How about nuts? All right. So nuts are good. And like I said a little bit earlier, I have nuts available. I have a whole canister of mixed nuts, almonds. There are some pecans, um, cashews, etc. And I'll take out maybe 4 ounces or so, 3 or 4 ounces, and eat them as a snack. And it suffices.
At Marlene's in bulk, they have these like curry cashews, and then they have these they're like everything bagel cashews, and I've been obsessed with those lately. They're so good.
Now the bagels, okay, if you're looking at your carbohydrates
Oh,
and if you,
it's just the flavoring, like like
oh, okay,
on cashews. So you don't even need the bagel.
right. I got I got going the other day. I was trying to do um, an extended fast during the day. So I thought, okay, how can I make this a little different? So I had a Starbucks, and it was a skinny Starbucks, which doesn't have a whole lot of oomph to it. And I put some extra coffee in it, and I thought, and I got my whey protein out, and it enhanced that vanilla flavor. Plus, it gave me protein to last longer during the course of the day.
That's a good one.
Yeah,
Yeah, any way to give you fuel for
right. So the protein doesn't have to come from red meat.
yeah.
Yeah, and we know that meat often exacerbates the inflammatory process in the body. Not inflammation of the joints per se, but the internal inflammatory process.
And we want to keep that down as much as possible.
Right. Yeah, I had family history of diabetes, and so all my life I've been cognitive of the fact that it could pop up. And I'm looking back on things, it would have blossomed in my own body had I not been paying attention.
And that's why you feel passionate about doing your expertise as you do now, because you've seen
Right.
that thing and how many people's lives it is affecting. Um and sometimes like like what you were saying, you were aware of the signs and also how to prevent it so it wouldn't get to that point. But that's why you're there in the community to help people um through that. And so it's just very wonderful what you're doing, Jeannie. Thank you.
Well, and with age, um, just as an example, let's say you have um, a bunch of beans, dry beans in front of you, and you count out 100. Take out the number of years that you are right now. Okay, so those are used, and if you've been um, uh, abusing your system with a lot of sugar, for every year that you abused your system with a lot of sugar, take out half again as many beans, and that's how much insulin you still have left to use. Does that make sense? So about 50% of those over 60 have prediabetes. That's what the statistic is right now.
Wow,
Yeah.
that's a lot.
So the amount of insulin and beta cell usage, once it's gone, it's gone. Okay. So you can't cure diabetes per se. You can lessen the amount of insulin that you need to use by your diet and exercise and things like that. But if you don't if you're not mindful of what is happening with your diet, eventually you're not able to produce enough insulin to convert the foods and the glucose and get them into the cells and working for your body. And that's why people are on insulin. So it's just how far back we can go. When we talk about, somebody asked me the other day, well, I just got diagnosed as having diabetes. Well, that means an A1C of 6.5. Well, that process in that person started 5 to 15 years before that. So had they been cognitive of the fact that this disease process is going on, they could have stopped it or really slowed it down.
And that leads into our next question perfectly. Are you able to curve the pre-diabetic diagnosis?
Okay, so you can slow it down. You, I, it would take a lot of effort to try to get the graph up here, but you can slow down your progression from prediabetes into diabetes. Yes, very much so. And part of it is that you decrease the insulin resistance. And so you're not using as much insulin. And so we say, well, diabetes goes into remission. Well, maybe you could use that term. I once had a patient improve his health, and I mistakenly, this is way at the beginning before I knew exactly what the terms to use and how they could be misinterpreted. I said, so it looks like you don't have diabetes now. Well, he misinterpreted that, or he interpreted it his way, and I didn't catch how he interpreted it. So he went and started eating whatever he wanted again. He says, well, I don't have diabetes now. Can't do that. So it just came back to haunt him again. So you can
Yeah,
slow it down. And a medication that we use for pre-diabetes is metformin. And it's, I'll get back on my soapbox a little bit for a second here, but metformin is worth its weight in gold. It really is. It doesn't harm the kidney. If you can't take metformin, it's because the kidney's already been harmed, not because of the metformin. And it does a lot of what the GLP-1s do. It sensitizes those muscle cells to the insulin to get the sugar into the cell. The other huge thing it does is it puts the brake on the production of glucose from the liver. It's huge. So, and it does a lot of other things. It decreases your risk of colon cancer, decreases your risk of dementia in African Americans. They're looking at it now for prevention of some cancers. It's kind of a wonder drug, and it's cheap. It's generic. So that's all I'll say about metformin.
I've heard of some people using cinnamon to help.
Right.
Yeah.
I don't know if you can eat enough cinnamon. I mean, I've seen people take it by the mouth, a spoonful. I'm not sure that I could do that, but I do put cinnamon in a lot of things just to flavor it. In my oatmeal as well.
Delicious in oatmeal for sure. Oh, folks, got any more questions? We'd love to hear from you.
And again, if anyone has a need just to talk, to bounce some ideas off of, or concerns, I do the half-hour consultation. Again, I'll ask that you fill out a form so that I have some ideas to where you're coming from and what your needs are, and then we can sit down and talk more at length.
Oh, and we had another comment. We use cinnamon in a lot of our protein preparations.
Yes. How do you pronounce your name? Sean?
It's a night.
Say that again.
It's a night, like nighttime.
Okay.
Beautiful
It's a
name.
beautiful name.
Thank you.
Oh, oh, thank you. Thank you. I'm so grateful for all of you that were here with us. And for those that couldn't be here, if there was any loved ones and friends, this will be on our YouTube channel later this week. And definitely check out any other previous classes that we got on there, like and subscribe. And
Elizabeth, I've got one more thing. If
yeah,
anyone wants to email me with their email address, I have a diabetic news and brief email that I send out 2 to 3 times a month. It's not going to be in your mailbox every day. On different cues, session or educational things that are coming up. In fact, the one that I just sent out yesterday had to do with there's a shred, with all of us that are doing our taxes and everything. There are places in Pierce County that you can take 2 bags of paper to be shredded for free. So, I've got that going out to folks if you want. And there's a take back medication day coming up across the nation, actually.
yay. Well, thank you. You're always sharing great knowledge for lots of health and happiness.
Thank you so much, Elizabeth. I've enjoyed this immensely.
Oh, for sure, me too. And definitely everyone, we're gonna have her back and hopefully it'll be in person. It'll be a really good class. So and possibly hybrid. Oh, Sandy said, what's your email for the newsletter? That's the email that's in that
My
comment.
type 2 diabetes coach.
Oh, great. Perfect. Everyone says thanks. Well, we're gonna say goodbye to our friends here on the recording. Goodbye.